Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to discuss stellate ganglion block for refractory VFib, VTAC, and electrical storm for patients with or without a pulse. And this one has been on the radar for a while. I've been waiting for there to be some actual literature. People have been talking about this for a few years, but really in a literature-free zone. There is literature now, and so I think we got to do the topic. This is not a hard nerve block, but you need to know your anatomy really well. And you need to have the basic skills of needle localization, and then you'll be okay. I wanted to get a true expert on the topic on the show, so I got Bob Stenberg, and I think it's going to be a great discussion. Now, most of the discussions around the indications, complications, how to do it, but you need to actually see it, right? You can't just learn a block by listening. So I have some links in the show notes for videos that you could watch, and I think that's going to be the way you really learn it. But honestly, once you learn the anatomy, you will be just fine. Sorry, this one's coming out a little bit late. I just got back from Japan, which was an insanely good trip. Amazing. I took my son there. He's been wanting to go forever. So I apologize for it being late. But if you want to talk about a Japan trip, because none of my friends have gone, then I am totally open to that conversation. All right, here's what I want you to know. Reanimate 11 tickets are now for sale. Reanimate is our resuscitative ECMO conference with VA ECMO, ECPR, Crash VV ECMO. It is in San Diego every year. It is November 12th and 13th. And it sells out rapidly every single year. Every single year, I keep doing these ads. People are like, I'll wait. And then they decide to buy their ticket 2 months beforehand, and we have none. And they're like, oh no, I wish I really wanted to come this year. I'm like, yeah, then you should have done it when I talked to you in January. So if you want to come to Reanimate, now is the time to buy your tickets. Go to reanimateconference.com. That's reanimateconference.com. Buy your ticket, and then you will not miss it again this year. All right, let's get to the show. Who are you and what do you do?
I'm Bob Stenberg, and I am the ultrasound director and fellowship director at Cleveland Clinic Akron General.
All right. So you actually approached me with this topic. What are we going to be talking about today?
I would love to talk about stellate ganglion blocks, particularly for ventricular storm or electrical storm.
Yeah, it's finally, I hit that critical threshold where I think we have to talk about it. I've had this in the hopper and there just wasn't a lot of papers on it. You know, people were doing it. I'm like, really? You're going to be sticking something to someone's neck in the middle of cardiac arrest? But now with the publication of the STAR trial and a few other meta-analyses, I think it is finally time. So it was propitious when you came and contacted me about this. Now, what's your experience with stellate ganglion blocks?
Our system has done a couple for some vasospasm in the setting of subarachnoid and other conditions on the ICU side. But we've just been really, after the STAR trial, we've really been ramping up our exposure. And it's really fun to do. It kind of combines that resuscitation and nerve blocks, which both things are really interesting to me. There's been a lot of really good outcomes in the literature and from talking to other people, and we've had some good results as well. So I wanted to reach out to you.
Yeah, I love it. Now, there's really, in my mind, 2 indications for emergency medicine. I love that there's that third indication in the neurocritical care unit, but let's just talk about ED specific for today. And so in my mind, the ones you'd actually be considering this in is a patient who has a pulse in electrical storm, so persistent VTAC. You might be getting geared up to send them to the cath lab because they're going to need to have that in their diagnostic regimen. And you would consider this, you've given numerous antidysrhythmics. Maybe you'll tell me you actually consider it much earlier than I have in my mind. But in my mind, for that patient, you've given amio, you've given lido, you're even considering giving Esmol at this point. Maybe you are already administering Esmol and you're like, this is getting ridiculous. We're just emptying out the drug cabinet. Maybe we should be considering a stellate ganglion block. And then the second case would be actually a electrical storm or refractory VFib in the midst of cardiac arrest. Which of those do you salivate over starting with?
I really love doing it during arrest. I think it's just a really fun challenge. And I think it's something that is really within our wheelhouse with our ultrasound guided skills and our resuscitation skill set. So
perfect. So let's start there. And so we have a patient in persistent ventricular fibrillation. And how far into the arrest, Bob, would you consider doing this?
I think this is the really big challenge. And the part where there's really not any specific guidelines. It's like, when do you go for that? And I think you could really, based on the situation, depending on how comfortable you feel doing that, since there are some theoretical risks with you putting a needle in the neck and dumping anesthetic into the neck. But I think it's that threshold where you've given a couple rounds of meds, you made sure that your pad placement's in a good spot. And I think it's at that threshold. And one of the things that I think that we've noticed in our shop is that I think we're doing it too late in the resuscitation to make it impactful because we're getting reduction in arrhythmia, but I feel like you're 30, 40 minutes in the case and it's approaching futility. So I do feel like I'm doing it more on the front end of that, but I think figuring out exactly where that fits in, I think is hard to know with the literature right now and guidelines.
Yeah, we define refractory at 3 shocks, right? So 3 shocks didn't work. Now we're refractory. So that's when I start thinking about bringing in like other things. And obviously dual sequential, if you haven't been thinking about it, is pretty huge this year with the publication of the DOSE VF trial. And by this point, after 3 shocks, I've probably given multiple antidysrhythmics. I'm considering ESMAL. I probably have asked for that second defib. It makes a lot of sense to me. This would be the time, somewhere around this 4th, 5th shock, because, and we'll talk about the patient with a pulse, the complication versus benefit, you have to consider. I think all that disappears in cardiac arrest, and I'm curious if you disagree with me, because they're getting insane doses of vasopressors, so the hypotension doesn't really concern me. And as long as someone knows what they're doing and you don't put an intravascular injection, I don't really see much downside to just adding this in. Am I wrong, Bob?
I agree with you. I really do. I think at that point of the resuscitation, I think the benefits outweigh the risks. I really do.
All right, so let's go through this logistically for a cardiac arrest patient, because I think that's going to be a harder logistics, even though it's easier from the perspective of risk benefit in my mind. So what are you going to call for? What do you need to do this?
Yeah, there's a huge variation even in the STAR trial in terms of what medication was used. And there's a little bit of debate about the volume as well, but really by the overarching compilation is really going for 10 mLs. Typically at that point, I'm calling for 10 mLs of 1% lidocaine. And I'm grabbing a nerve block kit, and then I'm going to get set up. So my setup is going to be ultrasound on the right side of the patient. I'm going to the left side of the patient, and then I'm going to just do like any other nerve block. So a lot of people are right-handed, and it almost works a little bit better being right-handed as well, given the anatomy. It's pretty helpful to turn the head to the right because that tends to get like the IJ out of the way to expose your targets. And then a really big thing when you're doing this in the setting of cardiac arrest is you're doing this during compressions, of course, but big anchoring. So getting that hypothenar evidence, just typically like almost sitting on the clavicle. That's why it's nice to be doing it right-handed. So you really get a good anchor with your left hand, but a really big component is anchoring on that.
All right. Yeah. I'm going to pause you before we go into the procedure itself, because I want to ask some more questions about the prep stuff. Now, when you say a nerve block hit, I know you know what that means and I know what that means, but let's really break that out for the audience. So you want a needle capable of reaching some distance. What do you guys actually use in your nerve block kit?
Yeah, so we carry both 5 and 10 centimeter needles, but I think the 5 centimeter needle has been really adequate for all the ones that we've done so far. I think it's the right depth. And when you start getting those 10 centimeter needles, you're just putting yourself at risk for going in too far, poking something you don't want to poke. And sometimes it's a little bit more challenging to manage those 10 centimeter needles. So I feel like the 5 centimeter needle is the right length if you have access to that. Also, too, because there's a lot of things you don't want to poke in that area. I think you really do want to use a nerve block needle or a blunt tipped needle. So if that's a spinal, if you don't have Quincke or whatever, so you really want to have that increased safety profile as you're approaching that target.
Weingart popping in here. So if you don't have a ultrasound block needle or just a regional anesthesia needle, we use the Payjunk. I really like this. They have a long extension set. The needles are really nice. They're incredibly echogenic. I don't take money from the company. If you don't have those, then you want a spinal needle. But what you don't want is the atraumatic spinal needles that actually have their orifice on the side of the needle. You don't want that. You want your standard traumatic, quote unquote, spinal needle, because the traumatic spinal needle is less traumatic than the needle you would get from, say, a central line kit or whatever, like a cutting needle. So you want the quote unquote traumatic spinal needle. 22 gauge is probably the size to grab here. Something like 2.5 and 3 inches will get you where you need to go. So that's what you will grab if you don't have a specific block needle. Now, are you having a syringe mounted, or when you say a nerve block needle, is it something that actually has some extension tubing so that the syringe is separate?
Yeah, so we use the Payjunk nerve block needles, and that's just one of the random companies. That one comes with the attached tubing. So we have a 10 ml syringe in our kit. So we will just draw up the anesthetic with the drawing needle and then just attach it right to that.
All right.
And then we just use a tegaderm as part of that as well. We don't use a full sterile probe cover, and that's going to be a lot faster as well.
And I love the nerve block needles. And I imagine you have someone helping you and you're saying inject when you want. Is that correct, Bob? Yeah.
Yeah.
It just makes the procedure so much easier. And it just means you could keep your hand exactly where you want it on that needle to guide it. Are you doing actual location through injection for this block? Is it something that you actually would be doing much akin to the other nerve blocks, or is this just you go in the general area and hope?
Yeah, I think it's fair to try to do a test bolus with some sterile saline or use some saline solution just to make sure you're getting some spread along that prevertebral fascia, that longus colli. I think it's fair to do that, but you get some time of essence at this too. So I think both are fair, honestly.
Have the compressions made this difficult?
It's harder. It is, but really that's where anchoring is your friend here. And I think it makes it manageable.
All right. When we talk about arterial access during cardiac arrest, especially for an ECMO case where it's so critical, one of the adjuncts we have found helpful is actually having someone holding above your site so that they're actually interposed between the compression movement and where you're going, and it actually will diminish markedly the amount of movement at, in this case, the groin. My guess is if someone was holding the upper chest down so that the compressions wouldn't transmit, that might, I haven't tried this for the neck yet, but that's my imagining. Now, I have placed, and I'm sure you have as well, IJs and subclavians during compressions, and it's doable. This seems like a little bit finer work. We're going for a smaller site here. Have you had an instance where you were just in the right place and then as you're injecting, the needle actually was displaced from where you wanted?
I've not had that happen. And the blunt tip needles do a decent job of holding in place too, from my experience. There's some jostling, but I haven't had a big needle dislodgement. And I'm maintaining one hand on the transducer, one hand on the needle the whole time, with both hands basically anchored to the bed and or the patient. We've not had too many issues with significant needle dislodgement.
All right, fantastic. Now, you said 10 cc's of Lido 1%. It would just make sense, and this is my theory for all nerve blocks, to just go with a denser block if I'm going to be doing the procedure. And certainly 10 cc's of Lido 2% is well within any safety limits. Why not 2%?
Yeah, and I guess it's a little bit I think it's a sufficient amount with the literature that's out there. And if I can mitigate the risk of LAS, that was the one major complication in the STAR trial. If I can mitigate that risk and use just what I need to use, I'm probably going to go for that lower concentration just to reduce that risk of LAS.
Yeah, that's one of the things about the STAR trial is that the choices of medication were pragmatic. And so they were all over the map. Things like bupivacaine, which is where I worry about the last, lidocaine, and then ropivacaine, which has a desirable safety profile, et cetera. And we'll talk about when we get to the logistics of the patient in STORM with a pulse, what your choices are for that and whether they're different. But for this, I guess if you get them out, you could always do something else after a secondary block or what have you. So you're sticking with the lidocaine short acting. And even if there was an intravascular injection, it really doesn't matter with your lidocaine choice because it's just going to be one more dose of lidocaine. It might actually be beneficial. It might actually be just what the patient needed. So I guess from that perspective, if you are not experienced with it, using lidocaine is really desirable because the biggest fear for me is injecting right into the carotid. And with lidocaine, 1%, 10 cc's, that's actually a bonus, not a error. We can just say, oh, yeah, it was a more close to the heart injection of the medication we wanted, right? We're just going to transcend the IO, IV trials entirely and just put it right into the carotid. Okay, so we have everything we need. We have the ultrasound machine. We have a nerve block needle. We have hopefully some separation from the needle in the syringe, a partner to help us inject. And we're ready to actually go now. Now, we're going to describe this, by which I mean Bob's going to describe this, but obviously hearing it verbally is going to be nowhere near as good as seeing it. So Bob has been nice enough to provide diagrams and description. So all of that will be on the show notes for this episode, but we'll run through it here. So why don't you walk us through the actual performance of this, Bob, and then people could go and supplement that with actually seeing it.
Absolutely. And it's all about keeping things simple. And this is a high pressure scenario, going to what you know. So the first stop is getting to your target. And so there's multiple ways to get to that target. One of those is you're trying to aim about the C6 level. And that is right about your cricoid cartilage. We practice feeling cricoid cartilage. We know where that is. So you can try to start about that level. You can also try to start looking for that longus colli deep to the thyroid lobe in that region. Some anesthesiologists will also recommend.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning. And then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
And if you're very familiar with the nerve anatomy, you actually start off in the supraglottic brachial plexus and sweep cranial until you actually see where those nerve roots are jumping back into their origin. So that's something else you can do. But I think practically I'm going to go right about where you go for an IJ. I'm going to go at about the level of the cricoid, and I'm going to start looking for that carotid and looking for that longest culli running deep to that carotid.
All right, so essentially our area of landing here that we're searching for is just posterior to the carotid artery. And it is, and this is where these nerve blocks always become a little bit more difficult, is you need to be behind or inferior to the prevertebral fascia. And there's a muscle there, and you described that nicely, and you can see that in the diagrams. And what you're trying to do is put it just above that muscle and below that prevertebral fascia. But if people see an IJ and they see a carotid and they're at the level of the cricoid, they're in the right zone here, and now they're trying to get the needle to be just above the mesial belly behind that carotid is essentially what we're trying to do here. What structures do we need to avoid in this pathway? And where I assume you're going like most people do from lateral to medial, right? Because there is this weird anterior approach I think people are using without an ultrasound that just seems like insane to me. I think for me, and I assume you, we're going to be restricting ourselves to ultrasound guidance, and we're going to be, do you ever consider using anything but that lateral to medial approach?
I don't think so. And I think as you do other different nerve blocks, I think it feels a little bit more natural to have that approach as well. So I think it feels a little bit more natural to take that approach and just feels a little bit safer to me as well. So I'm going to do that posterior lateral anterior medial approach every time. All
right. So what are we trying to avoid here? What is going to be the problems people are going to experience as they're going?
Yeah, one of the tricky things is that Chassaignac tubercle at C6, it's a little bit more prominent. So the first time I did this, I actually struggled getting around that tubercle, and I had to adjust needle anterior to get up and around it. So that is one thing, but that's just more of a barrier than anything else. There's a lot of big bads that you don't want to poke into. So at about that C7 level, you have the vert coming in. You also have the inferior thyroid artery. Ideally, you're not trying to poke the esophagus, which tends to be on the left side as well, since you're doing these all left-sided. Adding in the brachial plexus to try to not skewer a nerve root. It's also ideal. But the big thing is doing tiny sweeps up and down until we have a nice clear pathway to that muscle belly deep to the carotid. And then I always am throwing power Doppler or color Doppler on that area to make sure I'm not going to go through a vessel in that process.
You're searching your pathway for any vessels. And then essentially with the needle size we're doing, you're not going to do incredible damage to any of these other structures, but it would be really nice to avoid them if we can. So you're going to move until you can find what looks like a clear shot directly down there. And are you pulling back? Because I know a lot of listeners are not doing nerve blocks. And this might be one of only a handful of nerve blocks they've ever done. Now, you get an experienced person. Most people at our shop they'll be doing blocks for hips and they'll be doing blocks for shoulders. And so this, I think, is not any big ask to add that to their armamentarium. Do you think the standard ED doc who has not done nerve blocks should ever be attempting this?
That's a trickier question. I mean, I don't know if this is the time to have this be your first nerve block attempt, because it is a little bit trickier with all the compressions and just identifying anatomy. That may be a little bit of a stretch as your first nerve block exposure, but for people that are familiar with doing fascial plane blocks, like doing hips and other sites, I think it's very within our skill set at that point to try.
How do you teach your residents to get experience with nerve blocks? The problem I ran into is I did not want to be giving up a lot of these early on when I started doing nerve blocks. And then once I felt very comfortable, I was happy to let residents actually take the needle and I would just be there with the syringe. But a lot of the docs, they need the training, and teaching it to others is, so are you guys using phantoms and things like that? Tell us your regimen at your shop to get people up to speed on nerve blocks.
Yeah, and it's similar to other people. There's always an educational component, whether there's an asynchronous component or not, but we do have a couple simulators. And one of the biggest things that people really struggle with is maintaining needle visualization. So and you don't really need a human to work on your in-plane needle visualization. Getting a lot of good reps with a simulator. We have a fasciolata simulator amongst some other ones that we're going to use to get reps with needle visualization and just practicing that in-plane technique, which tends to be the biggest barrier. So doing that. And then we also will just supervise other attendings doing blocks too, to help get everyone up to speed. Having enough people comfortable is a big step. And we published a fasciolata implementation about how we navigated getting a group of docs doing these blocks. And I think one of the biggest things is it's challenging to get people to show up for extra seminars and meetings and courses. So having the simulator in the emergency department where you can just grab it on shift and be like, hey, get a rep with this quick. That was like really crucial to getting more people up to speed and getting comfortable with it.
All right. So now let's say you've successfully instilled that 10 cc's. How quickly do you expect to see an effect from this? And what would you see during cardiac arrest?
Really, the big thing is reduction in arrhythmia. Prior, it was always thought it was all you're looking for an anisocoria or looking for a Horner syndrome. But the STAR trial really demonstrated that a lot of people have significant reduction in arrhythmia without having any change in anisocoria or pupil size. So I think you're really looking for a reduction in arrhythmia. It's still going to take a minute or two to kick around, but you're hoping within 1 or 2 cycles of CPR that you're seeing that resolution of VTAC or VF.
Would you still give the esmolol? Because essentially these have the same general thrust in what they're trying to do if you just did a stellate ganglion block.
Yeah, and I think that's really tricky again because we don't have any literature to support that. But I think it would be fair to just see where they're sitting after the block, and then we weren't getting with that. Either some people would even consider going to a right-sided block at that point, or going for esmolol at that point.
What, and I'll insert this where it belongs, spreading in the right plane, and what does it look like when it's spreading in the wrong plane as you're doing this?
Absolutely. So you're looking for that kind of, the big kind of visual thing is taking it look like you took a zipper and kind of zipped it on down where that fascia blank opens up. If you're in the muscle, it's just a kind of bunch and bubble up. So instead of having a smooth, clean spread, you can also sometimes see that carotid actually get lifted up superficially a little bit as well. But really the big thing is it looks like a kind of unzipping of tissue, and you should not be seeing a bunch of tissues kind of like bunch and bubble up, especially that muscle belly. And
if you haven't punctured the prevertebral fascia, what's that going to look like?
You may not see much at all, and it may be pretty minimal, and sometimes it's going to be a little bit challenging in that area in terms of what fascia you're in exactly, but they're supposed to be decently contiguous as well.
All right. What else should we talk about in cardiac arrest?
I think that's a big thing. And I think just one of the biggest tricky points is just where does this all fit in? And I think just doing it at 40 minutes into your resuscitation, I think is some version of too late.
Yeah. So you're definitely pushing earlier. And so if you had this patient, they're 60 years old, they had some chest pain, they're in cardiac arrest, they come in, they got in 3 shocks by EMS, they're yours. Tell me what your sequence would be of meds versus stellate ganglion.
Yeah. I mean, if, a lot of times I would probably amio, lido, and then I think I'm probably going at that point.
All right.
And that's definitely on the aggressive end, but I'm probably going to do 1 bolus of lido and then I'm probably going to go.
Got it. All right, cool. Let's move then to the patient with a pulse. They're just in persistent electrical storm. Are you guys doing this, or is this more of a post-cath thing for a patient that they can't break out, whether it is by checking the coronaries or some form of EP? Where does this fit in?
Yeah, and I think we have not had a scenario at this stage where we've had opportunity to do that, but I think I would still definitely do that in this scenario. I think one other piece in this patient is just because there's some decent evidence supporting them having some deep sedation on board, I would make sure that they're intubated and heavily sedated prior to attempting this, which would also hopefully make the block a little bit easier to do as well. So they're hopefully going to be moving less. I think that's one kind of piece that would get sandwiched in there, would be adding that intubation sedation in that scenario.
It's funny you mentioned that, because that's when I've been thinking this through. That's my spot for doing this, is if I'm willing to intubate the patient in order for them to go to the cath lab, then there's probably no reason not to try this at that stage before they go up, because A, it's so easy. They're not going to move around. They're not going to have pain. And B, it's like, all right, we've already done something far more invasive. At that stage of the game, would you be giving, again, the short-acting lido, or would you reach for something like, in my place, it would be ropivacaine, where I'm not really worried about last, but I have much more potential to keep them for 12, 16 hours if this works. So what's your take on that?
I really see both sides of that. I think it's still fair to do the lidocaine. And then I think one approach would be you give the lidocaine if they're still, under your care, but the light was starting to wear off, but it worked. At that point, maybe I would consider just reblocking and doing the bupiv and dex at that point.
Got it. And you mentioned dexamethasone, and that's been in the literature. And we know that in a lot of places, steroids increase the potency of blocks. Have you been doing that for your non-stellate ganglion blocks? Anesthesia does that quite frequently. It hasn't really percolated into the ED space. Tell me your thoughts on that.
Yeah, I think the literature is pretty darn good for it to extend the duration of the block. We are not doing any block catheters. We're doing all single injection blocks. We're doing a lot of bupivacaine and dex.
Okay.
We're doing for renal colic or hip fracture, whichever indication, we're adding the dexamethasone. We do it the preservative free because there's some thought that preservatives in there have some neurotoxic components. So we always do it with preservative free dex, but we tend to add dex to our blocks for extended duration.
Bob, why still bupivacaine?
Yeah, that's just what we have at our shop. And I don't have a great answer for that beyond that.
All right, fair. All right, what else should we have spoken about in terms of stellate ganglion block?
One thing that we didn't talk about would be complications of the block.
Let's do that.
One of the tricky things about the complications is when you start looking up the literature on complications of stellate ganglion blocks, there's some pretty sketchy stuff on there. Dural puncture, hemomediastinum, some crazy infections. But a lot of those really were all done in the setting of a landmark-based approach. And when you look at the newer literature for this, like the STAR trial, the complications are pretty minimal. And I think that kind of further supports doing this with ultrasound guidance because you're just ensuring you're injecting it into a safe location. There's some evidence also for fluoroscopy, but that's not something you'll be doing during arrest. So I think this is really an ultrasound guided procedure to minimize your complications. And the most common complications are really, you can catch like recurrent laryngeal nerve. So you can get some like hoarseness, some dysphagia. You can get some spread into the brachial plexus, but again, that's going to be some transient thing that will resolve. So it's really not anything to be alarmed about. The one major complication in STAR trial was that case of LAST, which actually resolved with giving lipid emulsion. So it was someone that was not intubated and they just had some respiratory suppression from the localized systemic toxicity. They got lipid emulsion and they did okay. That was the one major complication in the STAR trial, which I think is our most up-to-date piece of literature. There are some theoretical complications, but especially in this scenario, I think that come back to that risk-benefit ratio.
Yeah. The other complication to mention with the patients with pulse is hypotension. That's an expectation. The whole thing you're doing is knocking out their sympathetic tone. And that's not an issue in cardiac arrest because we have transcended any endogenous catechols by a factor of about 100. If that was the case, if you were doing it in a patient with electrical storm, I would just put them on a primarily alpha-based agent and support them and they'd be fine, I think. All right. Fantastic. Anything else we need to hit, Bob?
I can't think of too much else. I think the big take home is really adding this to your armamentarium. There is also, I looked this up, there is actually someone in Europe enrolling it for an RCT right now. So I think there's going to be hopefully some more literature coming soon that will further kind of cement this into our algorithm.
Absolutely. And I would love to see that. And that's going to be super helpful. But at this stage of the game, I think this has more evidence than most of the things we do in cardiac arrest electrical storm. So at some point, once you've past the first 3 or 4 rounds of meds and shocks, you're in a completely evidence-free zone. And so this does have more evidence than most of the stuff we're doing at that stage. So I think you'd be well supported if you did implement this prior to the RCT being published.
Yeah, that's fair.
All right. I can't thank you enough, Bob. It's been fantastic speaking with you. I'm so happy you contacted me.
Thank you so much.